Uncommon and rare tumors, also called the borderline tumors, tumors of low malignant potential that can be serous, mucinous, or endometrioid histology, and are commonly found in the reproductive age, middle age women. For women who have not completed childbearing, fertility preserving surgery that can be offered. So, bilateral adnexectomy, that is a curative in this case. An advanced disease may manifest with either non-invasive or invasive peritoneal or omental implants, and because these tumors have a small population of cells in this actively dividing pool, they tend to be resistant to most anti-neoplastic agents and cell cycle specific. So as a result, late recurrence is common in this class, and according to the AGO retrospective multi-center outcome in borderline ovarian tumor robot study, a largest data set available on the borderline ovarian tumors, recurrence occurred in 7.8% of the patients, with disease progression in the form of invasive carcinoma occurring in 30% of the relapse. Inadequate surgical staging, residual tumor, fertility sparing surgery, and a high FIGO stage, they were associated with a shorter PFS. No difference were observed in for laparotomy versus laparoscopy or application of the adjuvant chemotherapy. Mortality was 4.5%. So first is malignant germ cell tumor of the ovary, which accounts for approximately 5% of the ovarian cancers, and with a median age of occurrence is 19 to 21 years. And they are almost always unilateral and exquisitely chemosensitive. For this reason, fertility preservation surgery is always optional for this disease, and even when metastases are present. Among the different subtypes, radiosensitive dysgerminoma, bilated in 10% in cases, elaborates lactate dehydrogenase and alkaline phosphatase and is characterized by lymphocytic infiltration. The yolk sac tumor spreads hematogenously, elaborates alpha fetoprotein and is characterized histologically by Schiller dual bodies. Immature teratoma forms neuroepithelial rosettes that serve as a basis for the Norris grading system. Elaborates both alpha fetoprotein and human chorionic gonadotropin. The mixed germ cell tumor, embryonal carcinoma, non-gestational choriocarcinoma, and a dreaded polyepidembryoma. Therapy for malignant germ cell tumor mirrors and has been extrapolated from more common testicular tumor cancer experience, except for FIGO surgical stage 1A dysgerminoma and stage 1A grade 1-2 immature teratoma. Patients with malignant germ cell tumors of ovary should be treated with adjuvant bleomycin etoposide cisplatin. Prognosis is excellent for patients with this class of ovarian cancer, with return of normal menstrual function being the rule and numerous successful pregnancies documented during the follow-up. So accounting for less than 5% of the ovarian malignant tumors, neoplasms, sex-caused stromal tumors can be broadly separated into estrogen secreting tumors, that is granulosa cell tumors, and juvenile granulosa cell tumors, and the testosterone secreting Sertoli Leydig tumors. Although GCTs, they are usually diagnosed in women in mid-50s, whereas juvenile GCTs typically diagnosed in children and adolescents, and both types of tumors have been reported across the age spectrum. Coffee bean nuclei call exon bodies observed. Serum levels of inhibin A, occasionally inhibin B, that can assist in the preoperative diagnosis of GCT and can also be used to monitor patients with recurrence. Estrogen made by GCT can induce neoplastic changes in the endometrium and manifest as uterine bleeding from hormonally driven, typically endometrial hypoplasia or carcinoma. In children, hormone production by JGCT results in an isosexual precocious puberty. Lymphadenectomy can probably be omitted for surgical staging of these tumors of the absence of grossly enlarged node. Most GCTs contain a mutation in the FOXL2 and the presence of the GSP oncogene and a high GATA binding protein 4 GATA expression on the JGCT may provide new prognostic marker among young patients with the JGCT. And the fertility preservation surgery that should be instituted, although most patient with the GCT present at an early stage can be cured, over 80% of the patient with an advanced stage will die. BP, bleomycin etoposide and cisplatin regimen used for the malignant GCT of ovary and demonstrated activity in GCTs, but response have not been durable and long lasting. Certainly Leydig cell tumors, they cause virilization due to high level of testosterone. Surgical resection is usually curative, and patients with advanced Sertoli Leydig cell tumors may respond to gonadotropin releasing hormone analog. And gynecoblastoma is exceedingly rare primary sex cord stromal tumor of the ovary showing morphological evidence of both male and female differentiations. And finally gonadoblastoma, that is another rare that has been primordial germ cell and immature Sertoli or gram cell cells.